Well, we're not going to take super long time here. We just wanted to let the committee finish asking you questions that they had. And I'll start by asking kind of a tough question that comes out of what we just heard with the patients. These are expensive products that aren't covered often by insurance companies. We've heard that over and over again. And in fact, I think when you were talking about your own pharmacy, Hook Pharmacy, you're talking about $1 per milligram, and if you something like that, and it can easily add up. So my question is, if you were, and maybe several of you can answer this, but if you were going to put a pie chart of the total cost of these, where is the cost coming from? Is most of it the complicated cream itself? Is it the FDA approved ingredients? Is it the high touch pharmacy and working with the physicians, et cetera? Can you just kind of draw that pie chart for us just as kind of a background?
I'll go first. So this gets into a fairly interesting conversation of this business model of not working directly with the PBMs, Medicare, Medicaid, those types of things. So our pricing model revolves primarily around the raw ingredient costs. So when we're talking about the use of drugs like ketamine, off the top of my head, I'm trying to think of the most expensive ones. Ketamine and clonidine, not so much. Ketamine just jumps out of the head. That's kind of the gabapentin is a little expensive. Amitriptyline, depending on strength. That's going to be the real driver of cost. So there's two ways that we mitigate that. One, again, going back to start low, go slow. We're not dispensing 200, 300, 400 grams of this stuff at a time. We start with the patient at 15, 20, 30 grams. So they're off the top of my head, not looking at the data right in front of me, their initial out-of-pocket costs for their first prescriptions run 35, maybe 50, high-end 75 to start with. Mm-hmm. But the other component of this is that given the independent nature of my pharmacy, we're an independently owned community pharmacy, and I'm not dealing with the bureaucratic nightmare, if you will, of the PBMs. And we can have a 3-hour-long discussion about how all that works. But I've got flexibility depending on the patient that's coming in on if we're going to handle a patient gratis. So if we have a patient that comes into us and we know a bit about their socioeconomic background, typically that'll come from the prescriber. I have a prescriber I work very closely with that we go to the same church, and he sees, for the most part, probably about 80% Medicaid patients. Most of the patients that he refers over to me, we just do out of our pocket, no charge to the patient. And that's the flexibility that we've got. I know this is not a 1 in a million situation, but it's not common. But we really do try to mitigate as much of that cost as we possibly can. And the main primary point of that is to start with lower amounts to begin with to make sure that we're going down the right track. And then, we kind of leave it up to the patient at that point. If we find something that works, if they want to get larger quantities, as it is with any other type of business outside of healthcare, you buy more in bulk, you get a lower price per gram, so that we'll start working with them on those individual things. The one part I think from the talk before, one thing that we do at our pharmacy is that before we start with anything, pain cream or not, anything I prepare at the pharmacy, we always contact the patient first and let them know what that price is before we start doing it. For me, it's just a smart business sense. I don't want to be making a bunch of things that then the patient goes, well, I can't afford this, or can we explore different options, and then I've got product that I can't use. We always talk with the patient ahead of time about costs. So there's a couple different layers there that we use to mitigate that. But the flip side of that coin, the numbers that were presented in this last presentation, that's not uncommon when I've got patients that are getting 2, 3, 4 months of the medication at a time. That's kind of gets into that $200 to $500 range, depending on what the active ingredients are.
Okay, that's helpful. If I want to fill in that pie chart, it sounds like the drug itself is the most expensive. And the excipient, is that a fraction of the drug cost?
Going off top of the head, I would say 50 to 60% of the cost is driven by the API, the bulk drug substance.
Okay.
15 to 20% is probably driven by the excipients or the bases that we use for the topical medication.
And so
then the rest is
35%.
kind of overhead, so.
35% then labor of the
Labor,
pharmacists,
overhead,
which
yep.
is very different than many industries where it's 80% people.
Right.
Okay, it was just the broad spectrum we wanted.
Yep.
Other questions?
If I could add to that, we've talked a lot about bulk drug substances being used in compounding, but there are times when a finished product is used. So they'll take an approved, say, lidocaine, prilocaine cream as a component of the finished preparation, or perhaps even use a gabapentin capsule, or finished products sometimes are used in compounding. It's not the most ideal way to do it from just you can make a cake starting from cupcakes, but it's a lot better to start from the pure substances. But that does occur, and that can contribute to sometimes an increased cost depending on which products that we're dealing with.
So would that be something that's commercially available or created in a B type pharmacy versus an A?
No,
or
B or A. I'm just saying that sometimes the components used in compounding are finished products. Yeah.
So just some follow-up in that regard. So if many of these medications, these compounded products, have 3, 4, 5, 6 ingredients in the active ingredients, does that mean that, then really the cost of a medication that has 4 or 5 ingredients in there is truly 4 or 5 times as expensive? Or I'm just asking here in that regard. I'm trying to understand, if I go to 6, is that twice as expensive as going to 3?
Mark, you jump in. You go
They have varied costs. Like he was saying, ketamine's expensive. Gabapentin is expensive. We like to use ketoprofen versus flurbiprofen because of cost. Flurbiprofen is much more expensive. We use ketoprofen. So we're always looking at ways to cut the cost.
And I'll also add about some of the clinical approach to choosing what might be an appropriate formulation for a given patient. How do we determine if a patient should receive a prescription for a customized pain cream that contains 1 ingredient versus 2 or 3 or 4? I had a conversation with a physician yesterday, and he said, well, if I have a patient with osteoarthritis of the knee, what would that formula look like? How much should that cost? And my answer is that simple diagnosis is key for helping us understand some of the etiology of the patient's condition, but it doesn't necessarily tell us enough about the pain for how we're going to treat the pain, because it's the specific symptoms that the patient is experiencing that's going to guide the choice of the actual API, as well as the concentration of that API and the application frequency. So is it dull and throbbing versus sharp and stinging? Is it worse upon movement? Is there a referred pain? Is there a trigger point pain? What are the other components that are involved? And based off of that type of information, they may need something as simple as an anti-inflammatory like a ketoprofen in a penetrating vehicle. They may need a combination therapy, but that's determined not by just the diagnosis of what the condition is, but by symptoms as well. What is the patient experiencing? Just the same as if these were all FDA-approved medications that are being dispensed, we're looking at what are the specific conditions we're trying to treat, what are the symptoms that the patients are complaining about.
Follow up in that regard, then, that is a really interesting approach there, but I understand that many providers, as they choose these products, go by a prescription sheet that has a diagnosis for neuropathic pain, for osteoarthritis pain. They don't go by for sharp stinging pain versus for burning pain, for dull throbbing pain. And if that is really the relevant information, then where can providers or the pharmacists who educate them about it, where can we get that information?
So I believe that this cuts to the heart of the issue, which is education. How do we get educated on the appropriate approach to pain management, whether it's from customized medications that are compounded or otherwise? If you have a pre-printed sheet that has a list of diagnoses and associated therapies, my understanding, and FDA can chime in on this, is that you as a compounded preparation, you cannot make any false or misleading claims. Therefore, if you're claiming that a formula would be appropriate to treat a condition, you need some literature to support that evidence. In the absence of that literature, it may be considered a false or misleading claim. And that's a statutory requirement, federal statute. So really the other aspect to better answer your question is education is the key. If the acknowledgement is that the therapy has value when wielded appropriately, and the key is education on how and what is appropriate, then that's the next step that we would love to engage in a conversation about how to get that education out there.
I know there are other questions. Do you have a question? Sure.
Yeah, I have a quick question about the transdiffusion cell studies that you perform. So when you do such studies on the compounded products, do you have some kind of a target profile that you're aiming at, or are you comparing your product with some reference product? How exactly would you do this?
Yeah, no. The simple answer to that is no. There were a variety of different formulations tested, and granted, the data is only specific to that specific formulation. In large part, it was looking at the ability of. We looked at a variety of different vehicles, not just one vehicle, but it might be the same API set, but a variety of different vehicle approaches, and compared them to one another, and look at their flux values. When we first started down that path, it was really to look at, are we able to get a polar substance and a lipophilic substance, we looked at two different drugs, into and through human skin with whatever vehicles we were testing. So it was, that was the nature of the study.
More from a formulation development approach.
Yes, that's correct.
Gotcha. Thank you.
Another component to build off of something that Dr. Shrewsbury mentioned before lunch is that the pharmacokinetic profile, the comparison to an FDA-approved product, for example, tells us one part of the puzzle. It doesn't necessarily predict how this patient is going to have a clinical response to a particular dose of a compounded preparation. It helps us understand that we do expect a degree of absorption. We do expect some clinical outcome, but it's not necessarily a predictive value of dose response for an individual patient. We spent a lot of time before lunch talking about pharmacokinetics and talking about the serum concentrations. And I know that there's going to be a lot of other opportunity to discuss it with some of the physicians in the next panel. There are FDA-approved diclofenac products that are oral and topical in the United States. And there's information about the serum value for both of those dosage forms, those routes of administration, at the approved dose, which has been found to provide adequate pain relief for patients. Similarly, in the UK, there are additional NSAIDs. So ibuprofen, diclofenac, and ketoprofen are all available in both topical and oral dosage forms. And there, again, are studies showing the difference between the serum concentrations from those routes of administration. So the principles of how this is utilized, even just looking at the NSAIDs, are not novel. And so we're essentially building on that.
You keep saying evidence. There's ketoprofen and ibuprofen, I think there's reasonable evidence that they benefit over placebo. It seems to me, though, that the amount of evidence that exists for most of the other products that get used topically is either missing or very minimal. While there may clearly be benefit to giving it to some patients, as we've heard, and I'm completely in favor of trying to figure out who those might be, I guess what I would ask you is that you're working with physicians and trying to help them design a product. We don't know that any one of the things we put in works, and yet we're talking about putting 4 or 5 in. And I guess I don't understand the underlying principle there. What is it that you're basing that information on?
So as part of this committee work, PCCA has been engaged with the National Academies on this project, and we did provide several charts, several spreadsheets worth of data, primary literature articles that looked at the topical.
Yeah, but they're all observational data, and I mean, look, we've looked at all of that ourselves, and so There are there no randomized trials for gabapentin topically that show that it works. I mean, there are no randomized trials for even clonidine topically working. The patch, yes. The topical preparation, no. So I'd be happy to look at your spreadsheet, but I'd be surprised if there's anything we haven't found. So I guess what I'm getting at is how do you advise physicians about what to try and put in? And it may be, I mean, let me give you an example. Patient takes gabapentin, seems to work, but they're very dizzy when they take it. So let's put it in a cream. I have no idea how it works that way, but that's fine. I mean, so that's what I was trying to get at, is sort of how is the advice provided? This is a side effect. We think this might work. I mean, and then the second issue is, are there formats that you put out for people to look at to try and help them decide?
We have a number of questions here, so I'll let you answer that briefly, and then we've got 4 or 5 other people that want to ask.
Oh, sorry about that.
Oh, I don't know if that can be a brief answer. I think all of us would love better data.
Yeah.
And unfortunately, I think, and one of the excuses for not having the data would be funding, and the fact that we're not Pfizer with focusing on the development of a singular drug product. We all this. So as I was listening to you, I was thinking back to when this all started to hit our world in a more profound way, which was actually in the 90s. And it was generated by physicians approaching pharmacists saying, look, I know some of these particular pain syndromes and the neurotransmitters that are involved, with the transmission of that pain, and can we and here are these drugs with known pharmacologies, and can we apply them topically?
So
that was the approach.
Right.
Okay?
So let me help Deborah get to the other questions, because
Yeah.
So you're doing it on a sort of a pharmacologic or a physiologic approach based on what we know, and that's fine. I understand. That was a simple answer.
Okay, thank you. Listen, Dr. Shrewsbury has to leave by 3:15. Are any of the questions that we have for him? Ed, go ahead.
Yes, I was going to preface it, but I know he's on a short time frame here. So, but I want to go back to the educational end of things. And you mentioned that there's companies out there that want to teach pharmacists, and I think one of them's represented on the panel here, how to compound. And I think several questions briefly, but sort of what's the incentive to those companies to do that teaching? How does that differ from what's being done in the academic world? And kind of, what's the general landscape out there in terms of teaching pharmacists beyond their college education, I guess?
In what is taught in schools of pharmacy varied, where sometimes they just get one semester of compounding, and you try to do both sterile and non-sterile, and you could imagine that gets to be pretty short. And there are other schools that have 2 semesters or 3 semesters, so there's a variation in that. The other thing comes down to the faculty members that are involved in teaching. Most schools of pharmacy generally have 1 faculty member that's going to take that on. In our survey, we found that there are some schools that have up to 3, but most of them are down to 1. So given, and schools are like everything else, there's so much money, and I'll just tell you, compounding is one of the more expensive courses to teach as compared to a lecture course, for example. And so all those things go together to decide how much you can get done, how much curricular time you have, how much money, and all that. So, said that, there are always people who really think that compounding is quite exciting, and I vote for that. And so sometimes they say, well, what else can we do? And so in the academic area, you can make up a special project, and you can have students work on projects and that kind of thing. The other thing that you can do is offer an elective course if you don't happen to have one, and you can design it to be a lot of different things. The one that I have, we investigate how you make formulations, and it's kind of student-driven, but that's another side issue. And then the third thing is to say, well, okay, there are other avenues that are available to you that I'm aware of, and there are these programs that are being offered about BHRT or pain or, whatever it is. And if you're really interested in doing it, perhaps you'd like to attend one of these things. So that's how it all kind of works into being.
Carol?
I wondered what mechanism, if any, you have in place for collecting adverse events. And if you have something in place, do you quantify and qualify those, as in it's a local effect, it's systemic effect? Is it enough magnitude to have the person stop using their cream? So is it just a passive, you wait for somebody to call and say, hey, I used your stuff and I got a rash? Or do you have a procedure in place for collecting that information?
We're not a pharmacy, so we don't have that data, so I'll defer to our colleagues here.
Go ahead.
So in our pharmacy, one of the things that we do is we do the follow-up call. 7 to 10 days after the patient receives the medication, we give them a call, and that's where we ask the questions, are they having any side effects? And if they are, we address that then. And we also make notes in the patient's profile about that side effect. So that would be our documentation.
Carmen?
So I have a question and follow up Dan's part of that question. Why is this so expensive? I mean, the medications that you're talking about, are off a patent. I mean, so why is it so expensive to get these raw materials?
That'd be AJ.
I mean, is it something special about this that, I don't know? I mean, what is it why amitriptyline, which is an ancient drug, why is it so expensive?
So, as with all things, you can get things very cheaply. And the quality of those products and as well as the regulatory acceptability of those products may not be there. So, finding a quality manufacturer of pure pharmaceutical grade, USP grade, amitriptyline, gabapentin, ketoprofen, lidocaine, any of these ingredients that we use, which is required by statute. And that manufacturer is also registered with the FDA, and they have had a recent inspection and passed the inspection. They haven't been shut down. They haven't had to do a recall. These are expensive manufacturing processes, and add to that, most manufacturing is not conducted domestically. Some is, and if it is, we always go with those manufacturers. The reality of drug supply is that most manufacturing of pure ingredients is overseas. So then you have other import taxes, and then, of course, we can't just take it at face value that it is what they say it is. So we have additional expenses on our own qualifications, our quality tests that Dr. Pisani mentioned during his introductory remarks. All of these add up into the cost of the retail cost of what that powder is.
But these are drugs that are relatively inexpensive, done the right way through FDA-approved companies compared to other drugs, and they seem to be more expensive using them in this manner. Why?
I mean, amitriptyline you can get for $10, a prescription $4. I mean, a patient can walk in with a prescription. If they don't have insurance, they can get it for $4. Depending, I don't want to advertise.
Probably not the cost of it, but.
Pardon?
That's probably not the true cost.
Well,
$4.
then maybe somebody's
Copay.
making money or is losing
Yeah.
money. I don't understand. I need some help.
Amitriptyline is probably not a good example because you're right. It's not a very expensive product.
Well, he said
But-
it was, who was it? Said it was expensive. The
John.
previous speaker.
Yeah.
So,
He left.
Yeah. I think he was saying GABA or ketamine. Those are higher
ketamine
priced.
is a very old drug. So, yeah.
But the raw materials on a per gram basis may be expensive.
Well, that's true, because
But-
you're
but I
using 10
wanted to,
times the dose, right?
yeah.
Instead of 1%, you're using 10% or something,
Yeah, or
and
5%,
the skin.
Yeah, but also I don't know that we've really talked about the actual retail prices of these things. I heard somebody say $1 per gram as one example, but my understanding of the marketplace is a lot of these are what, $60 to maybe $200 at most per month, or somewhere in there, for the products, which I don't know if you've looked at drug prices these days, but that's not a whole lot compared to some of the things that are out there. It's thousands of dollars for things that have been generic for a long time.
And that was echoed by the previous speaker about the consumer costs. And when there is no prescription coverage for even the FDA-approved products, they can't afford those products. And a lot of the chain pharmacies do loss leaders, the $4 generic programs and things like that. Those are loss leaders to get people in the store. Those are not things that you can do even with those FDA-approved products in an independent pharmacy. The economies of scale aren't there.
Joyce?
Yeah, I wanted to know more about how the decision is made of what to give a patient, how many drugs to combine. Do they need that many, depending on their condition, I guess? Is that partly a conversation between the physician and the pharmacy? Do they take into account what else the patient is taking? And also, do they take into account whether there are any interactions among the drugs, either in the mix itself or with the other things they're taking? For example, I think it's benzodiazepines will prolong the effect of opioids. How does that all happen?
It all starts, a lot of times we just consult with the doctor. If I'm treating a arthritic knee, then the doctor wants to put an anti-inflammatory in there. And also they also want to put lidocaine because it gives the patient some relief when they're applying it. And we also maybe look at the mechanism of action. Why do we put gabapentin in there? Because it'll block a calcium channel on those nociceptors. And, we're trying to break that wind up that's happened with that pain. So that's the kind of choices that we're making as far as selection of ingredients.
Do you ever go back and then take out one of the drugs, like in these people with 7 things in them?
So we don't do 7 things. I mean,
Okay.
That's out there, but
Or even
honestly,
5 or 4.
We're 3 and 4, and yes,
Okay.
we do. So if I were to start a patient on a cream that had an anti-inflammatory in it, also with my conversation with that doctor is once we get that patient under control, let's remove the NSAID because it is not good for the cartilage. So we want to get their pain under control and try to remove the NSAID. And then and a lot of patients, a lot of times when we get their pain under control, they don't have to continue with the pain cream.
2 quick questions. One comment and 1 quick question. So Dr. Carr, you want to make a comment?
Just a quick comment, which is, I think in the deliberations of the panel should be included a sense that it's not generally possible to go from the symptom, like burning, tingly, electric, to the pathophysiology, to the choice of the agent. These are very helpful. In fact, those who work in the pain assessment area know there was a scale developed by Ronald Melzack called the McGill-Melzack scale that had a whole series of descriptors derived from patients in the clinic. It has been tested. It can have some predictive value, but it goes far short of what is capable of being done today. For example, with very simple clinic or bedside assessment of light touch or temperature sensitivity, there have been now worldwide collaborative studies involving thousands of patients that cluster what previously used to be viewed as the single entity of neuropathic pain into several sub-entities. So one of the sub-entities might respond very well to an anticonvulsant. Another doesn't respond at all to an anticonvulsant. So we should be very cautious and not get down the wrong pathway at the very beginning by saying if it's burning, use this, if it's tingling, use that, or the other. These can be suggestive. If we have resource-limited environment, they can be appropriate, but I think would be a mistake to go down that pathway.
Thank you. I've been having an ulcer here because I wanted to say that about 5 questions before.
Go ahead,
Because
Diana.
somebody made a comment that really concerned me. And I have done surveys on thousands of people with pain. You can't just say 1-to-1. So if you say, well, if they told me that they had this and they had that, we could have had 3 more ingredients. It's just not that straightforward. I've done research with McGill. So really, human nature and humans
are very different. And if you went from one country to another, you'd find different descriptions for the same etiology of pain. So I really would say if you're going to educate the providers and the patients, don't do it on a symptom-based thing. People are very susceptible to suggestion, and a regular doctor's just going to say, oh, okay, then we got to add that drug. No, because you're going to end up with polypharmacy and a cream, if that's possible. Anyway, thank you. Now I can breathe again.
All right, thank you. We appreciate you staying and answering our final questions, or at least a series of more questions. And now we'd like to switch out panels to the provider panel, please. Thank you.